I have the special privilege to introduce the next speaker. Dr. Shaurya Taran is a clinical associate in critical care at Toronto Western Hospital. He completed his MD at the University of Ottawa, followed by training in internal medicine and critical care at the University of Toronto and a neurocritical care fellowship from Harvard University. His clinical and research focus is in neurocritical care with work published in leading journals. He has contributed to Canadian guidelines on brain death determination and is involved with the Neurocritical Care Society's Curing Coma campaign. He is currently pursuing a PhD in clinical epidemiology at the University of Toronto and is leading multiple international research projects aimed at improving the quality of mechanical ventilation in patients with acute brain injury. And the topic that he brings to us is very interesting, the interaction of the master organ, brain, with the lung, the little crosstalk. So we are talking about mechanical ventilation in neurocritical care patients. Over to you, Dr. Shaurya.
Thank you so much, Dr. Singhal, and thanks everyone for the very kind introduction today to speak on a topic that's very near to and dear to my heart, mechanical ventilation in neurocritical care patients. I think we have 30 minutes or so allotted for this talk, of which about 2/3 of the time I'll be spent going through these slides, and I'll be very happy to answer any questions in the last 10 minutes. So the objectives for the next 20 minutes or so are threefold. We'll start by reviewing considerations for selecting tidal volume in neurocritical care patients. We'll then pivot to understanding the impacts of positive and expiratory pressure on various intracranial physiologic indices, including intracranial pressure. And we'll conclude by briefly reviewing considerations for prone positioning in patients with acute brain injuries. I have no relevant disclosures for this talk. So starting with objective one, guidance for selecting tidal volumes in patients with acute brain injuries. Many of you will have seen very likely this consensus recommendation from the European Society of Intensive Care Medicine, published by Chiarova and colleagues now 6 years ago in ICM, where they ask if there are specific mechanical ventilation settings we should be using in patients with brain injuries, and focusing in particular on tidal volumes. And across these various combinations of clinical scenarios that deal with different levels of ICP and lung injury, there is strong recommendations in some areas to use lung protective ventilation with low tidal volume, weaker recommendations in other areas depending on how to balance these conflicts between brain and lungs, and no recommendations in other areas. What's important is that across all of these different recommendations, there's really no data to guide clinical decision-making. Admittedly, this is now a 6-year-old document, but actually very little has really been updated in the last 5 years to change the strength of these recommendations. Now, why would this be? Well, we know that the use of low tidal volume ventilation may lead to clinically important hypercapnia. In your general ICU patient, this might not be significant, but indeed in brain injury patients, it very well could be. This is data from the first 7 days of the ARMA trial, looking at patients with low tidal volume ventilation, 6 mils per kilo, and comparing their daily CO2s with patients who received 12 mils per kilo. And you can see across each day, days 1, 3, and 7, there was an average of about 5 to 7 millimeter mercury difference in CO2s, being significantly higher in patients with low tidal volume ventilation. And the same was also shown in patients without ARDS, where comparing low tidal volume to higher tidal volume ventilation, CO2s were about 4 millimeters mercury higher in patients with the low tidal volume ventilation. Again, this is in patients without ARDS. Now, as alluded to previously, this may not be such a big deal in patients with general ICU conditions, but in neurocritical care patients, it can have important implications to intracranial pressure in particular, and that reflects this relationship that you'll all be aware of. For every 1 millimeter increase in CO2, particularly between the range of PCO2s of about 20 to 80 millimeters mercury, there's about a 3 to 5% increase in cerebral blood flow. This is quite a potent relationship. CO2 is the most potent mediator of changes in blood flow. And in fact, the direct mediator is not the CO2 itself, it's the changes to the perivascular pH. So as CO2 rises, for example, with the implementation of low tidal volume ventilation, diffuses across the blood-brain barrier, acidifies the perivascular pH, and that acidification of the perivascular pH is what leads to vasodilatation, in particular of the PL resistance arterioles. This augments cerebral blood flow and cerebral blood volume, the latter of which potentially leads to an increase in intracranial pressure. The converse is also true. As CO2 comes down, the perivascular space alkalinizes, you get vasoconstriction, decrease in cerebral blood flow, a reduction in blood volume, and potential reduction in ICP. And we can leverage that principle, for example, when patients are having ICP crises. This is actually quite nicely demonstrated in graphics, including with blood flow imaging studies, where, excuse me, when you lower the CO2, you get a very potent reduction in blood flow as seen on these fMRI studies. And then when the CO2 is allowed to increase again, for example, in this case, between images 2 and 3 from 34 to 56 millimeters mercury, you get a very potent blood flow response that can potentially lead to elevated blood volumes and ICP. Now, there's probably more than just physiologic implications to this. There is some observational data, admittedly not very high quality, but still suggestive that higher CO2 levels can be associated with worse outcomes. This was a secondary analysis of a large observational study that found that hypercapnia, as defined by CO2 greater than 45 millimeters mercury, was associated with worse outcomes, in this case, mortality in a broad group of patients with neurocritical care conditions. The same was also true for very low CO2. You can see the point estimates are about the same for when the CO2 is very low versus when it's quite high, in this case above 45. And it's probably for this reason, among others, that historically clinicians were actually quite worried about using lower tidal volume ventilation. This is a longitudinal study with data collected at several time points. You can see that in 2004, among patients with acute brain injuries, only about 4% of patients received less than 6 mils per kilo predicted body weight of ventilation in terms of their overall ventilatory days. The majority were receiving 8 mils per kilo or higher of tidal volumes. But there's increasing recognition that the CO2 effects are probably very highly patient dependent and reflect important baseline physiologic characteristics of a patient's brain injuries. And in particular, an important determinant of the CO2 effect on ICP is patients' baseline brain elastance. So here we have ICP on the y-axis and blood volume on the x-axis. You can see that when elastance is low in this brain here, I see the sulci nice and wide open, the ventricles are open, there's no midline shift, there's good preservation of gray-white matter. For a small change in blood volume mediated by an increase in CO2, the corresponding increase in intracranial pressure is actually quite low. The converse is true for when brain elastance is very high. So in this case, the brain is very tight, the gray-white differentiation is lost, the sulci are barely visible, the ventricles are extremely small. For that same change in blood volume mediated by the same change in CO2, in this case, the intracranial pressure response may be much more potent. So CO2 affects very highly depending on patient's baseline intracranial pressure. Another way of quantifying this is the pressure volume index, which essentially tells you how much the volume within a given space has to go up to make a tenfold increase in pressure be seen. And essentially, the lower the pressure volume index, the more susceptible the patient is to very, very large changes in pressure with very small changes in volume. So there is some reassurance provided by recent data that, again, the effects of tidal volume on ICP can be highly patient dependent. This was a single center randomized crossover trial where patients with acute brain injuries of various causes were ventilated first at baseline conditions of 9 mils per kilo and then at intervention conditions of 6 mils per kilo. And the investigators were essentially recording different lung and brain indices with these different changes. So patients received the baseline ventilation settings. There was a washout period where things were allowed to normalize, and then they switched again to the intervention settings, testing both PEEP and tidal volume in different scenarios. When we look at the tidal volume scenario, again, where patients are dropped from 9 to 6 mils per kilo, you see interesting results when you compare the ICP. So at baseline settings of 9 mils per kilo, you can see that the average ICP for all of the patients is listed on the left. And as the tidal volume is dropped, there is a very small increase in intracranial pressure across most patients. You can see that most of the points on the right are higher than on the left. But in most cases, it seems to be reasonably well tolerated. The delta difference between these sides is not very large. However, indicated in red are patients where the intervention had to be stopped because the intracranial pressure reached the stopping limits. That is to say 22 millimeters mercury for more than 5 minutes. So the takeaways for me, at least from the study, are that in most patients, tidal volume reductions in patients with brain injury will probably be tolerated with minimal consequences to intracranial pressure. But there are some patients, as indicated in red here, where the response could potentially lead to an unsafe elevation in ICP. Thankfully, it is actually, we care about who these patients are in clinical practice, because if we know in advance that the ICP is going to increase potently, then we can either mitigate it or be more cautious with ventilatory adjustments. And thankfully, why I really like this study is that these authors then looked at factors that can predict the so-called intolerance to a reduction in tidal volume. And what they found actually was that baseline ICP was an important predictor of who could tolerate the tidal volume reduction without an unsafe elevation in intracranial pressure. So for patients where the baseline ICP was high, the median here is about 17 millimeters mercury. There was a higher likelihood that the intervention had to be interrupted versus if the ICP was lower, for example, median around 10. They also found mechanical power to be an important determinant of the ICP response. This figure here goes back to the concept I'd shown earlier, where the CO2 effects really do depend on baseline elastance. So if baseline elastance is higher, for example, reflected by a higher ICP, one might potentially need to be more cautious, as mentioned with the tidal volume adjustments. This has been increasingly recognized in clinical practice, where just as our tidal volumes in general ICU patients have trended down over time, so too have the tidal volumes in patients with brain injuries. You can see from the same study presented earlier, when we follow patients out in 2010 and 2016, the average tidal volume is going down. Again, this is just in neurocritical care patients. By 2016, we're at an average already of 8 mils per kilo predicted body weight. And the proportion of patients that are receiving what we would consider conventional lung protective ventilation within the order of less than 8 mils per kilo is also increasing with time. So where does that leave us when we're left to manage tidal volume considerations in patients with brain injuries? What I like to do here is think about what is the dominant physiologic threat between the lungs and the brains and the brain, and try to balance physiologic considerations across those two organs. In many cases, the physiology will allow you to set a tidal volume that is both brain friendly and lung friendly. In some cases, you may need to choose what is the more pressing concern and adapt the ventilation paradigm accordingly. So for example, if we have a brain injured patient, the ICP is normal, the lungs are normal, you could probably start somewhere around 6 to 8 mils per kilo, as you would for most general ICU patients, again, ignoring a lot of the nuance that goes behind individual selection. The important thing here is you want to target a CO2 of 35 to 45 millimeters mercury in the absence of intracranial hypertension, and then use essentially standard approaches as you would for other ICU patients. When we start to encounter potential trade-offs, if you have really high ICP and normal lungs, again, you might start with the same tidal volume settings and then adjust maybe a little bit more within that range to keep the CO2 closer to 35 because you're worried about the CO2. But the caveat here being that you want to absolutely avoid permissive hypercapnia because of its implications for ICP. When you have a situation with both high ICP and injured lungs, this is where things get a little bit more challenging. It's hard to have direct data from the existing literature to guide practice. A lot of these considerations are very, very much made on a case-by-case basis. You want to start with lung protective ventilation with low tidal volume, increasingly look at additional safety surrogates such as the driving pressure and the plateau pressure to guide individualization. Try as much as possible, again, to keep the CO2 close to 35. And again, priorities may evolve. If lung injury dominates as the primary threat, you may want to target a more lung protective approach, but there may also need to be some considerations or concessions for ICP, i.e. you may not potentially get as lung protective as you want because of implications to ICP. And this is where kind of the individualization and personalization of ventilatory strategies becomes important. So that was what I had to say about tidal volume, and we'll move on now to PEEP. Mainly to make the point that as clinicians, we're still overall quite cautious and potentially even reluctant at times to use higher PEEP in patients with brain injuries. This is some work that we did using local data in Toronto, where we compared PEEP over time in patients with and without brain injury, and found in general that PEEP across the first week of ventilation tends to be lower in patients with brain injury than it does in other ICU patients, and that hasn't really changed over time. Now, that's not so important on its own because potentially there may not be a need to use higher PEEP in these patients. But when we focus on the subset of brain injury and non-brain injury patients who have hypoxemic respiratory failure, where there may be a physiologic or clinical indication to use higher PEEP, it still appears to be the case that brain injury patients receive lower PEEP than patients without brain injuries. I think part of the reason for that might be because of this concern that clinicians have about the effects of PEEP on ICP, and that we think is that the PEEP goes up, the ICP naturally will also rise. But if there's nothing you get out of this talk, I hope I can at least impart one message. It is that the impact of PEEP on ICP is actually quite complex. So in fact, yes, increasing PEEP can increase ICP, but it can also paradoxically almost decrease the ICP or have no impact on the intracranial pressure. And the net effect, so how will PEEP impact ICP, depends on the factors that dictate cerebral blood volume in the first place, i.e., what's coming into the brain, which is the arterial inflow, and what's leaving the brain, which is venous outflow. And PEEP affects each of these components differently and potentially sometimes in opposite directions. So let's look at how PEEP affects both venous outflow and arterial inflow, try to get a sense of this physiology from both sides. So venous outflow from the brain is dictated by a Starling resistor. You may have seen this concept before. So as blood enters through the arteries and traverses the capillary network, it then exits through the cerebral veins, enters the relatively rigid cerebral sagittal sinus before draining into the thorax through the jugular veins. Now, as long as intracranial pressure is higher than CVP and sagittal sinus pressure, you get this Starling resistor that develops at the junction between where these veins enter into the sagittal sinus. We don't typically measure the sagittal sinus pressure, but we do use the CVP as a reasonable surrogate under most physiologic situations. Now, the impact of any PEEP increase or CVP increase on ICP will be minimal as long as the intracranial pressure remains above the sagittal sinus pressure. So if ICP remains above sagittal sinus pressure, the Starling resistor remains closed, and there's no passive blood obstruction out of the cranial vault, and therefore there should be minimal effects on cerebral blood volume. But if PEEP is increased to the extent that it raises CVP and sagittal sinus pressure, then if this increase exceeds or gets very close to the intracranial pressure, then this Starling resistor becomes lost. You develop conditions for passive blood flow through the circuit, and the blood has a hard time leaving the cranial vault. In this case, venous outflow is impeded and the cerebral blood volume can rise, potentially increasing intracranial pressure. So that's only on the venous side. But as I mentioned earlier, what's important for the overall balance of PEEP on ICP also depends on the arterial side. So on the arterial side, we know that arterial inflow depends both on what's given to the brain by the heart, but also on the brain's own autoregulatory capacity, which could be intact or impaired. So as we know, cerebral blood flow follows this relatively sigmoidal shape, where flow becomes relatively pressure passive outside the range of autoregulation, but within autoregulation, the brain has mechanisms, typically through vasodilatation and vasoconstriction, to keep mean arterial pressure and blood flow and arterial volume relatively constant. So for a given increase in PEEP and a reduction in cardiac output mediated by, again, the decrease in stroke volume, if autoregulation is impaired, that slight reduction in mean arterial pressure may not have much of a consequence because the brain can enact counter-regulatory mechanisms to keep arterial inflow preserved. In that context, blood volume won't change. On the other hand, though, if the brain injury is severe and autoregulation is impaired, flow becomes pressure passive, as we know, and the autoregulatory capacity of the brain, again, is lost or heavily attenuated. In that case, for a given reduction in cardiac output through an increase in PEEP, you might have a reduction in blood inflow and blood volume. This is assuming that we're not doing anything else to counteract the cardiac output reduction with the PEEP increase, for example, not giving more pressors or fluids. This is a relatively simple schematic just to illustrate general physiologic principles, but I think we've all seen many aspects of this actually play out at the bedside. So depending on what's happening on the venous and the arterial side, you may have various combinations of PEEP increasing blood volume on the venous side, reducing it on the arterial side, and so on and so forth. I won't go through all of them, but depending on this tug of war that's happening between the venous and arterial side, the net effect of PEEP on ICP can either be to decrease ICP, no effect if those two situations counteract each other, or an increase in ICP if again, the patient falls within this category here. So it's really hard to predict in advance what might happen, but we do have a couple of clues. And I guess before sharing those, I want to share, again, the same data from this physiologic single center study where they looked at different effects of PEEP on intracranial pressure. Again, in this case, they went from baseline conditions of PEEP of 5 to study conditions of a PEEP of 12 and looked at the ICP response. You can see that in most cases, the ICP increase was small, but there were, again, some patients in whom the ICP did increase, which reflects this concept indicated previously that the effects can be either negligible or indeed can increase the ICP. And there may be some cases even where the ICP decreases between the two conditions. So again, it's hard to know, but there are some clues that can help us decide what the response to an increase in PEEP will be before we actually enact it. And I use these at the bedside quite a bit. I'm on clinical service right now, and I've done one or two of these assessments already in brain injury patients. And so the first is the gradient between the central venous pressure and the ICP. So as mentioned, when the CVP starts to get very close to the ICP, the effective PEEP is going to be more pronounced. This was shown in a couple of single center studies that I've highlighted in the references here. And this group, Panga and colleagues, actually showed that the effect on ICP is more pronounced when the difference between ICP and CVP happens to be less than 2.5. So let's say the ICP is 12 and your CVP is already 10. In that patient, I might be cautious of PEEP elevations just on the basis of that data point alone. There's obviously more to consider, but that is a helpful one. The other important thing is head of bed position matters. So the supine position of patients increases the transmission of right atrial pressures to the brain, so that for a given level of PEEP in the supine position, the ICP impact may be higher compared to when the head of the bed is placed at 30 degrees. This becomes relevant, for example, when you're transporting your patients to scanner or for long scans in particular, like MRIs, or where they have to lie flat on an angiography table, for example, for aneurysm securing. You might have to be very cognizant about PEEP when patients are in that flat position because of the ICP impacts. And the other important and often neglected principle is the contribution of chest wall versus lung elastance to the overall respiratory system elastance. If the chest wall elastance is high, so think morbid obesity, intra-abdominal hypertension, ascites, so forth, people have in those patients a relatively greater impact on ICP. It'll lead to a relatively larger rise in pleural pressure, compared to transpulmonary pressure. Whereas if lung elastance is high, then PEEP may have less impact on ICP. So if your patient is very highly recruitable, for example, and also tends to have a brain injury, it might be that PEEP is increasing transpulmonary pressure more than it is pleural pressure, and the ICP impact therefore is minimal because venous outflow can stay unobstructed. So how do we put this all together? Pay attention to the ICP-CVP gap. Be cautious when that gap is very narrow, especially below 2.5. Try to avoid systemic hypotension when increasing PEEP. Of course, this is generally good practice for all patients. But be especially cautious when brain autoregulation is impaired, because that hypotension can actually reduce cerebral blood volume and cause cerebral ischemia as a consequence. And then we want to try to minimize PEEP-related overdistension. Conversely, however, don't be afraid PEEP to prevent de-recruitment in the right patients, because there may be physiologic benefits that we're not taking advantage of if we are afraid to use PEEP in our brain injury patients. So that was what I had to say about PEEP, and I'll very quickly close with prone positioning. So just very quickly, from time to time, we do have patients with bad brain injuries and also a severe hypoxemic respiratory failure in whom there may be compelling indications, at least from the lung side, to prone the patient. In our neuro patients, the data suggests that prone positioning probably increases ICP patient dependent, but if you look at various case series put together, the median increase in ICP across those studies is between 3 and 13 millimeters mercury in the prone position. On the other hand, it also probably increases PO2, P to F ratio, and in patients who have brain tissue oxygen probes in place, we do notice in many cases an increase in PbTO2 with prone positioning. So there may be some benefits to proceeding with this, and the presence of brain injury on its own shouldn't be seen as a contraindication. The consensus statement mentioned previously does say to consider prone positioning when you have concomitant ARDS and brain injury, but no ICP elevation. They weren't able to make a recommendation when you have ARDS and elevated ICP. There is some data in this population to guide our practice a little bit further since the publication of that consensus statement. This is a really nice single center study that looked at the impacts of prone positioning on ICP and tried to determine factors a priori that would predict that an ICP increase before proning was actually done. So in this study, they found that all patients with an ICP above 17.5 millimeters mercury before proning had ICP elevation during proning sufficient to stop the proning session. So in my mind, when we're approaching higher ICPs, I become cautious about proning, and I try to do everything I can beforehand to reduce the ICP, whether that be osmotherapy, CSF diversion, sedation, deepening, so forth. In this same study, patients who had ICPs lower than 17.5 before proning, actually the majority, 3/4, did not have ICP elevation for the remainder of the proning session, which in this study was 16 hours. So relatively reassuring. When the ICP was 17.5 millimeters mercury, again, there was a subset, 5 out of 18, that did have ICP elevation. But among those patients, if the ICP didn't elevate within the first hour, this maneuver could be completed without ICP elevation. So the first hour in patients who are being proned, at least for me, is important to determine kind of as a litmus test what the overall tolerance to the rest of the proning is going to be, assuming that their brain injury is stable, not evolving, and so forth. So in my practice and at my center, this is not a contraindication. We occasionally do prone patients. I've done it several times, paying attention to the ICP before the session is done. Some contraindications to be aware of are those listed here. So any unstable C-spine injury, of course, is in fact only really the only major contraindication to proning. Everything else is relative. In patients with severe brain injuries, ICP monitoring here is crucial, given what I've said about the potential to elevate intracranial pressure. So you really want to be doing this with invasive probes. Despite the literature suggesting evolving non-invasive ICP parameters being used in some cases as reasonable surrogates for invasive ICP, I really don't feel comfortable enough just on the basis of non-invasive ICP to prone a patient. If I'm really considering it, I want an invasive probe in place. Other things we can do, use the reverse Trendelenburg position to maintain the head of the bed gradient, keep the head midline. If there's a dominant jugular vein, try to keep it up and non-kinked. Tighten, loosen cervical collars, and try to pad the shoulders and abdomen as much as possible. And there are cases where refractory ICP may develop, in which case the proning attempt might have to be aborted. So to leave time for questions, just to illustrate some final takeaways, usually lung and brain goals tend to align. It's often possible to achieve lung and brain protective ventilation with careful tidal volume and PEEP adjustments. When these priorities come into conflict, you may need to adjust based on what is the more dominant physiologic threat or priority. I do like to use monitoring to guide therapy, both brain monitoring and lung monitoring. And then ventilation is only one lever. So if you're worried about ICP or the impacts of PEEP and tidal volume adjustments on ICP, there are other things you can do to control the ICP preemptively that can allow you to become lung protective as well. I've mentioned some of these things and they're listed here again. And this is often stuff that we do together in order to, again, make ventilation as brain safe as possible. I've listed some additional resources here that highlight some of the principles we've spoken about. Some of the graphics in particular come from this paper written with Professor Georgopoulos from Crete and his research group that provides some physiologic explanations in a bit more detail. And I'd highly refer to this. I continue to highly refer to this paper in my practice because there's a lot here that I find quite helpful. With that, I'm happy to take any questions and always also happy to be reached by email if we don't have time for all the questions here.
Thank you so much, Dr. Taran. That was a very informative talk. We would welcome any questions if there are any. So, Dr. Taran, we were talking about permissive hypercapnia and everything. You have to tell us your experience in case you do not have an invasive ICP monitor in place. How do you go about it using permissive hypercapnia in the absence of an ICP monitoring?
That's a really good question. And the bottom line is, again, ignoring some nuance. If I'm worried enough about ICP, then I don't use permissive hypercapnia because I don't know what the effects of the CO2 rise on ICP are going to be. It's not a situation. In fact, it's also there's some consensus statements put out recently by the ESICM that also suggests that if you're worried enough for the CO2 rise to have ICP consequences, that you not be using non-invasive surrogates of ICP. You really do need ICP monitoring. Taking a step back, the interesting question of why you might consider permissive hypercapnia in brain injury patients is that there could be some instances where the CO2 elevation and the CBF increase mediated by the CO2 can be favorable. So I'm thinking about, for example, angiographic vasospasm, delayed cerebral ischemia in patients with subarachnoid
That
hemorrhage.
was probably my next question. Yeah.
Yeah.
Permissive hypercapnia in patients expected to have vasospasm.
And in
We
fact,
heard
also in the ongoing Boost 3 trial, looking at brain tissue oxygen probe monitoring concomitantly with ICP monitoring, there are situations where if the PbTO2 remains low, less than 20, it's recommended in the algorithms to increase CO2, but only when there's an invasive monitor in place, because CO2 increases can increase CBF. That increase in CBF can increase PbTO2. But if you don't know what the ICP response is going to be without measuring ICP, then it shouldn't be done because there's the very real possibility that it can cause an ICP crisis, and you wouldn't know that unless it's measured.
any other questions from anyone?
Can I have a question?
Professor Bochard. Yeah.
Shaurya, very
Please go
nice
ahead, sir.
presentation.
Yeah.
Thank you. I noticed the importance of the CVP, right? The central venous pressure. I'm not 100% sure, but I had the impression this is not a classical recommendation in TN ICUs and brain injured patients to monitor CVP. What do you think?
It's a good question. Indeed, not classic. There are so many things that can affect the reliability of CVP. I think it really depends on the center where you're practicing. I think at Toronto Western, we probably, in patients where we can get a CVP, we do look at it a bit more when we're considering PEEP adjustments. I'm trying to recall back to when I was at the TNIC at St. Mike's as a fellow, whether we were doing this, and I think I agree, I didn't see it very much. The only reason where it could potentially be helpful is if that gap is very small, right? So if the CVP to ICP gap is small, then anecdotally, I mean, I don't have a lot of evidence to back this statement up beyond the one single center paper that I showed you by Peng and colleagues. It does seem to correlate with the slightly higher risk of ICP elevation when the two numbers are very close together. Conversely, I might be a little bit more reassured that an ICP increase won't happen so much if the CVP and ICP numbers are very separate.
Thanks.
Thank you.
There's a question, Dr. Vasudha.
Yeah. Okay, so the question is, Dr. Taran, both the ProLabi and Venn-Brain study points against LPV. Any reasons behind superiority of liberal tidal volume over restrictive tidal volume?
That's a really good question. I wrote the editorial for the ProLabi study, and my close collaborators were part of VentiBrain. So this might be like a long answer, but I'll spare the nuances of that. It's true that in the ProLabi study, this was I believe, 8-center randomized trial, including 190 something patients across Italian centers. A lung protective ventilation approach with less than 6 mils per kilo and higher PEEP was associated with worse outcomes. A composite primary outcome of short-term mortality, ARDS development, and ventilation-free days. in the short term, plus also potentially worse neurologic outcomes compared to patients that receive more than 8 mils per kilo and at PEEPs of 5. In VentiBrain also, higher tidal volumes were linearly associated actually with better outcomes. There's some nuances here. How they defined lung protective ventilation was different across studies. Prolabi only recruited about a third of the patients it intended to enroll. So it was likely underpowered to show the finding that it purported to its primary outcome. The fragility index of the study was low. It was only 2, and one of the composite primary outcome measures was development of ARDS, which in that study also required looking at chest radiographs to assess for bilateral infiltrates. And we know that the inter-rater agreement for doing so, even within that trial, was quite low. So how ARDS was defined could have potentially also modified the results. This isn't to say that we should be doing this on all patients. Prolabi also looked at less than 6 mils per kilo, which is also quite low, and it's possible that many patients with brain injury won't need ventilation with tidal volumes that low. So in my practice, I had a couple of slides around this trial before, and I took them out for the sake of time. I don't necessarily set a floor for what I consider is too low, but on the basis of this preliminary evidence and also evidence from the observational VentiBrain study, I do start to get a little bit cautious when tidal volumes are approaching 6 or below. On the other hand, if patients have a very strong lung reason to need low tidal volumes, and it similarly allows for safe driving pressures or plateau pressures, the presence of the brain injury on its own is not going to necessarily dissuade me from that. Conversely, if patients don't have significant lung injury, they have severe brain injury, maybe I start to set 6 in my mind as a somewhat arbitrary lower limit and try not to go below that. This is all still quite hypothesis generating stuff, including within these 2 studies, but yeah.
Dr. Taran, I have a small question about the mode of ventilation when the ICP is high. So classically we use volume control or pressure control, and it's just a physiological point actually, because no mode is preferred as far as I know, and there are no real studies also that look it up. So the mean airway pressure would be lower in VCV as compared to PCV, and the venous return depends on the mean airway pressure. Do you think that makes sense to use VCV in these situations?
That's a really good question. I must say, I don't know. I don't know the answer to that. I guess maybe I'll turn it around and ask, at your center, do you use one or the other in brain injury patients as preferred mode, just based on that physiologic benefit potentially?
Yeah, so there's no recommendation for this, and I tried to look it up. There are no real studies also.
Yeah, I must say I don't. In where I practice, volume control is just institutionally probably the more common of the 2. And so I just have a little bit more familiarity with using that, and including in our brain injury patients. I don't know if I've seen enough of a difference to say for sure that the ICP impacts differ from one mode to the other.
Any comments, Dr. Vasudha?
So as a matter of fact, it is a default mode for all of us, using VCV for all brain injured patients. I don't know whether using PCV really affects. I mean, is there a difference between the 2 in comparison in a normal patient? I don't know. We use VCV as a default.
All right.
Dr. Burchard, what are they doing at TNICU? Is it protocolized or?
I think they use VCV also for the reason we discussed. My guess would that it would depend very much on not so much on the mode, but the I/E ratio. So the I time much longer if you use PCV because you want to maintain limit pressure, for instance, may result in higher mean airway pressure. But again, it may vary from patient to patient. So I would not think a priori there will be a systematic clear difference between the 2.
Right. So thank you, sir, for the answer. So, Dr. Vasudha, there are no more questions, and I think we are coming to the end of the session, Dr. Vasudha and Dr. Sharan. Shall we close it?
Yeah, sure.
The session.
Please go ahead.
So, thank you, Dr. Vasudha and Dr. Taran.